Good evening. In fact, thoracic outlet syndrome is one of the important aspects of vascular surgery where we operate all the injuries to the ribs, injury to the brachial plexus, injury to the ribs and all that. It is a very crowded place where you have something like a junction box. You have the veins predominantly, the major vessels, the cutaneous and the significant nerves, they're all present. And that if you have somebody like rib, extra ribs are all present from CA, cervical C7, and you have T1, T2 are all, there is no extra loss of ribs. There is only an addition of ribs, and you get bony points. On the right side, upper X-ray, that shows you the extra rib there. And I will show you how to read the X-ray. Only the question they ask in the exam is how to read the X-ray and how to say it is an extra rib. I'll show you an X-ray. See, scalene is a mathematical name for a scalene triangle, and because you have a scalene triangle, you have the vessels in all the three sides are not equal. It is called as a scalene triangle. You have scar tissues around the tissues. It produces more often symptoms rather than regular cervical rib. Extra rib is present that actually comes into the scalenus space. You see the extra rib is shown by a red arrow. On the edge, you will find it is flat in nature. See, all the rest of the ribs are all sides will be uniform. Here it is sharp, and it is only and it is parallel to the clavicle. Well, the other one is flat outside. This is the only way to differentiate in the table when you are doing a transaxillary excision, and more so if it is on the upper clavicle side, you can detect the transverse processes and then find out the difference. This is the main question they'll ask you in the exam. The anatomy of subclavian artery, it is to take an arduous task of thoracic outlet syndrome in three phases. The three anatomical spaces are present. The ribs, articles, muscles, fibrous tissues, and tissue in crowd the place, postures, scars, and inflammation for further worsen the complications. You can see it has to pass through three anatomical channels. We'll show you. Subclavian artery passes through three channels. One is the scalene triangle, as we are known anteriorly, scalenus anterior, posteriorly, scalenus medial and posterior, and you have their first rib down. And any extra ribs, like cervical ribs, can be accommodated in the first triangle. Second triangle is where you have the costoclavicular space, where you have the first rib and the vein joins there. And the third one is the pectoralis minor space, is the coracoid process with the clavicle pressing the sternum as pectoralis minor and producing compression syndrome. Pectoralis minor syndrome, costoclavicular space, and scalene triangle. And all the three, somehow first rib is related. See, scalene triangle, costoclavicular triangle, the pectoralis minor space. Some interesting things of syndromes, pectoralis minor syndrome, is two types of muscles are there in the scalenus anterior, and they have different variety of contractions that produce symptoms in majority, and some may not have the symptoms. Total cervical rib produces arterial compression. If you have a total cervical rib, you have an arterial compression. Fibrous tissues due to scar tissues produce compression of the nerves. Historically, it was Hood who described the cervical rib and they did the cervical rib resection, particularly only fully formed, well-developed cervical rib. Then came the first rib resection by Murphy. Then Adson was very popular with Adson's test, and you had the sternotomy done in the 60s. Then Pete in 1956 suggested sternictomy and posterior approach by an orthopedic surgeon Claggett, and Roos' axillary approach was suggested in 1966, and Wurschel in 1982 suggested the use of nerve conduction velocity across the compression. When the ribs were described in length, there are 4 types of cervical ribs: complete ribs, incomplete rib with fibrous band, short piece of bone going beyond C7, and as for now, there is no physiological function of a cervical rib. It's probably like an appendix. First cervical rib was discovered by Galen and Vesalius because they are all anatomists. Cervical rib is estimated to occur in 1 in 500 people. That is regular X-ray chest taken in the hospitals in huge proportion, and you find every 500 only 1 cervical rib is estimated. Sir James Paget and Shorter described the Paget-Shorter disease. Nafziger and Ashner and Grant popularized the excision of scalenus anticus muscle. So now we have realized there are some compression syndromes which are compressing the subclavian artery, and the main thing that is compressing is the bony and the scalenus anticus. And scalenus anticus is histologically 2 different varieties, and the excision of scalenus anticus muscle is better than tenotomy of the scalenus anticus. So neurovascular compression management, or Wurschel of the Texas University, he has suggested neurovascular compression in thoracic outlet, and he has reviewed the last happening in the last 50 years. And then came the physical nature of arterial compression by hyperabduction syndromes, where people will develop pain when they hyperabduct. That is predominantly the pectoralis minor pressing on the artery and brachial plexus. The role of the first rib in causing symptoms recognized by many. People suggested posterior thoracoplasty, motor conduction velocities in thoracic outlet, etc. Then the genetic causes of cervical rib, then came the first rib. The gene cause of G6, GDF6, F3, myoxy cause Klippel-Feil syndrome. You might have seen it in vascular cases with excess of venous malformation and predominantly lengthening of the limb with varicose veins. We call it as Klippel-Feil syndrome. The protein produced for GDF6 gene is necessary for the formation of bone and joint, including the spine. Hox gene expressions lead to cervical abnormalities. The mutation is also linked to oncogenesis. So germ cell tumors, astrocytomas, and acute lymphatic leukemias were diagnosed in children at a high rate of cervical rib and other cervical anomalies. This is an interesting observation by scientists. All mammals have 7 cervical vertebrae. Swan has 24 cervical vertebrae. The long neck of the giraffe and camels have 7, while you have the long neck of swan and duck composed of 25 vertebrae. And the longest neck is from giraffe, which has got only 7 cervical vertebrae. And the presence of cervical ribs suggests a marker for a spinal deformity. The presence of cervical rib is the most common anomaly in the human stillbirth in occurs in 50 stillborn fetuses. Cervical ribs, therefore, appear to be a good indicator of disturbance of the organogenesis that presumably lead to medical risks. You can see the extra ribs awkwardly present. Anatomical spaces wise, neurogenic produces paresthesia and pain. Next comes venous, which is ghastly rare, 3%, swelling and cyanosis. It is in fact king of Navarare holding out the knife, and after the war was over, he developed Paget starter disease. Arterial TOS, only 2%. See, this is to easily recognize for cervical rib. C7 is your cervical rib, which is transverse. T1, which holds the first rib, is pointing upwards. So if you have a downward this thing, it is not a cervical rib, it is only a T1 rib, T1 spine. The incidence of cervical rib encountered in the routine chest films have been, I have told you, 0.5. It is occurs twice as frequently in women as in men. Watson-Jones criteria: if a well-formed cervical rib is formed, it does not produce neural symptoms. It produces more of an arterial symptoms. They were extensive in anatomical study of pre and post fixation of brachial plexus. The chances of you seeing a patient with vascular TOS, 1 in 500 cervical rib, 1 in 10 of the ribs produce pain, 1 in 10 neuro produces 1% of vascular TOS, and 1 in 10 vascular produces complications in 1 in 10. So it's rare. Vascular complications are rarer in the arterial TOS. Now, clinical history and assessment. Thoracic outlet syndrome is defined as an upper extremity symptoms due to compression of the neurovascular bundle by various structures in the area and just before the first rib and behind the clavicle. So it is called a thoracic outlet syndrome is any structure that can produce outlet obstruction, and they have found out the poor first rib, which is not related to it, is being blamed because it is claimed to be the denominator of the cervical space. Neurogenic thoracic outlet syndrome, history taking, choosing the correct treatment of correct timings and different treatment modalities for the patient is the key to the long-term holistic success. Don't keep on operating as the patient walks in like strangulated inguinal hernia. Don't operate in the evening. It has to be corrected, followed up, and psychological as well as pain management has to be assessed, and then only you can take the patient for surgery. At least a minimum period of 6 months have to be observed because it's very pain. Pain can be controlled and monitored with regular follow-up. Common theme of all presentation of a neuro-TOS is the presence of pain. Questioning should focus on the precise distribution of pain, its character, and what activities and postures exaggerated pain must also be assessed. There are certain physical tests. Accent test is one very popular this thing, where you hold the thing extended, turning the neck to the one side and contracting the neck muscles and reduction of absence of pulse. There was accent test. Then came the elevated arm stress test and upper limb tension test. So East Roos elevated arm stress test is now majority being used. Atson, who has described the Atson's test, is a very popular surgeon in cervical rib. He has classified into 4 types: fibrous band, incomplete rib, free and end bulbous, and complete rib with a joint. And the 3rd and 4th is supposed to produce more chances of cervical rib. An observation of good posture, rest, and the main treatment for neurogenic TOS. You have to have, even if you have better posture like a military position, it produces pain. Sitting properly also produces back pain and not able to sit properly. So posture and rest, either way it can produce pain. Posture, repetitive movements. What is this? Repetitive stress in the inflammatory findings are bad ergonomics of sitting in front of a computer, produces all sorts of back pain, keyboard problems, carpal tunnels, etc. And the deadly complication of vascular TOS is embolization. Whenever there is a compression by a bone on an artery, there is a post-stenotic dilatation. Post-stenotic dilatation is elevation of turbulence in that area, producing into eddy currents, and the whole thing dilates. Once it dilates, it is up to 50% dilatation. It is only a post-stenotic dilatation. Then you call it as aneurysm, post-stenotic aneurysm. But before it takes longer time. You can see that it's clavicle, and then up they have the first rib and then the thoracic rib, cervical rib. So it can produce embolic manifestations, and embolic manifestation can be very easily assessed by seeing a shower of emboli in the patients with severe pain and good radial pulse. And the presence of a thromboembolic manifestation is to be managed as an urgency. Eddy currents, turbulence, bruit, post-stenotic dilatation, and thrombolysis. Only to diagnose the swelling and a bruit in the supraclavicular region, and we can auscultate and find out the clinical findings. Embolization is the history as well as evaluation, and echocardiography for the heart, the source of emboli, or the source of subclavian artery producing embolic manifestations. You might have to end up in sometimes vascular surgery with graft with interposition. And then there are entrapment syndromes that are similar to thoracic outlet syndrome. You can have it in the popliteal area. You can have it in the celiac axis area, where the celiac axis of the aorta comes out from the thorax a bit earlier and then takes its meanders its way through the arcuate ligament. It gets compressed. You have the popliteal muscle or the gastrocnemius muscle compressing the popliteal artery. Or here, it is very interesting. The aorta, as it divides, it compresses the left iliac, common iliac vein, and then they produce edema of the lower vein on the right, left side. Surgical anatomy I have already discussed. Phrenic nerve on the muscle, inject, block by 5% xylocaine, and look for relief from the pain. If that gives a relief, then definitely first rib excision will definitely help. HRCT shows a mass of bony tissue in the clavicular fracture. That is because old fracture clavicle, when it heals with callus, it produces a big space, and as long as it is blood clot, it doesn't produce complication. Once it forms a calcification, it compresses on the nerves, brachial plexus, and subclavian artery. This is what I have told you. Anatomical narrowing of space around the brachial plexus, sometimes trauma and hematomas. This is a schematic representation of scalenus anteriorly, scalenus medius posteriorly. The nerve is the first to get cramped. The next, the artery is to be cramped, and the vein. In fact, the vein comes superior to the scalenus anterior, wrongly written here. And the common denominator is the first rib, which crowds the space. See, the last 3 decades, we were able to do 183 cases in a span of 3 decades. And the amount of vascular reconstructions that were included is roughly about 8 cases. So that tells you about the rarity of cases and need for a vascular reconstruction, because sternotomy can be easily done. Cervical rib resections are rarer, and first rib resections are equally rare but can be done through the first rib transaxillary route. Cervical sympathectomy is now taken over by the thoracoscopic VATS method by cardiothoracic surgeons and laparoscopic surgeons. Vascular reconstruction, only 8 cases are required in a span of 3 decades. Repetitive trauma, sympathetic irritation, and produces weakness, headache, paraspinal spasm, which all our computer personnel complain of. Pain, paresthesia, and upper limb aggravated by hyperabduction. Neck, shoulder, and upper aspect of pain, lower root problems. Vascular symptoms are embolic, I told you, work claudication, color change, and Raynaud's. Raynaud's can occur in both arterial as well as venous. Raynaud's is due to a vascular sympathetic irritation, produces the vascular free in the color change in the skin. Raynaud's. It can be painful or it can lead on to Raynaud's syndromes. Intermittent swellings, dilated veins, and venous claudication. Physical examination, told you about absent pulses, bruise, artery dilatation, supraclavicular fullness, etc. The vascular component of neurogenic arterial thoracic outlet syndrome was very well read and suggested by Ernest Molino in Angiology 2008. Coldness and color change are more often due to a neural compression. That is what we were describing about Raynaud's syndrome. So the autonomic neural is one thing which produces Raynaud's syndrome more often. Physical therapy is the first line of management. Change of position, stretching, differential diagnosis for neck pain is cervical spine pathology, neck pain, nerve compression syndromes, shoulder disorders, sympathetic diseases, carpal tunnel syndrome, and ulnar nerve compression. Apart from carpal tunnel, you have got also cubital median compressions, ulnar and median. Adson tests can be confirmed by a good vascular duplex probe in different positions. You take the compression, and if there is a gross reduction more than 50%, it is suggestive of a positive physical test by Adson. Then, physical tests are plenty, but basically they all include, people have suggested Lann, Allen, Wallen, Adson, Halstead, rules, costoclavicular syndromes, tests, hyperabductions, and yeast. There are names of various tests that basically they are compression of vital structures by muscle contraction. You elicit a contraction of a muscle in a particular way and evaluate all the things that happen in the distal arterial flow or pain. The screen tenderness locally, maneuvers which have been described already. The tests that are done is X-ray, Uplay, digital arteriography, imaging, dynamic imaging, and electrodiagnostic, nerve conduction, velocities, all that are assessed. But all that are not very suggestive in neurogenic TOS. Morley's test is the tenderness of the brachial plexus, where you have a neurogenic TOS, upper segment and the lower segment of brachial plexus. We find that lower brachial segment produce neurogenic pain more often than the upper bundle of brachial plexus. There is a syndrome called as disputed neurogenic syndrome that you have to not been found out the cause. They call it as it's suggestive of brachial plexus block where you do a Morley's test. Similarly, muscular aspect, diagnostic scalene block, it is useful in 50% in general controls where you have 97% is positive in people with TOS. And it can be done with open MR image guided injection by scalenus anticus muscle near the scalenus anticus. Color Doppler and duplex scan are easily available. It can be done to find out the vascular compression. This is also a duplex scan. Arterial TOS from the aorta, where you take all the external carotid as internal carotid and both the divisions of carotid arteries, all four vessel angios. It shows all the arterial flow, and you can see the compression at the level of subclavian. You must have read about absence of subclavian on the syndromes where you have a vascular ring. In the cardiothoracic setup, you have the left subclavian arising distal to the esophagus, comes posterior to the esophagus and joins the right upper limb. So there is an encircle of vascular ring produces dysphagia. And arterial flow, you can find out the cause of the arterial aneurysm, whether it is pseudoaneurysm or a real aneurysm. The difference is the presence of all the three layers. Angiography, you have a dilatation. Lipography is indicated in patients with venous obstructions. And then absence of pulse denotes total occlusion. Three-dimensional MR angiography in the evaluation of thoracic outlet is useful. Particularly in the veins, it can be useful for diagnosing and also treatment where you have thrombolytic therapy and completely excised segment, anastomosis with venous graft. MR neurography confirm types of syndromes. We have got various varieties of pain, upper brachial plexus, lower brachial plexus. So arterial TOS, acute ischemias, or claudication are asymptomatic. This is how they present. If it is an acute ischemia, thrombolysis and open removal. First rib and scalenus anticus reconstruction. Claudication needs pain evaluated by clinical tests. Asymptomatic CT angiography is done. And first rib excision and scalenus anticus reconstruction. Transaxillary first rib excision. It can be intrapleural, intrathoracic groove, or transaxillary. As you push your, I will show you. Neuro TOS, wait for 6 months, asymptomatic, CT angiogram, first rib excision, reconstruction. To take X-rays with hyperabduction postures to find out the arterial compression. This is nicely seen in the arrows. And the nerve conduction velocities, we have got F-wave analysis, EMGs, and the somatosensory evoke potentials. We are able to diagnose the level of block of conduction and might give a clue. Surgery for neurogenic TOS, goal of surgery is decompression of neurovascular structures at the thoracic outlet. Now it helps. Evaluation of therapeutic exercise program. Like what you do is for atherosclerotic cardiac running, morning walk, jogging and all that. You have an evaluation of a therapeutic exercise program where a person is supposed to do some specified exercises which helps the scalenus anticus. Neck stretching, shoulder raising, and all that. Proper case selection diagnosis, a minimum period of 6 months of non-operative therapy are needed. Don't operate within 6 months. That's what I was telling you. Yes, transaxillary excision is a very interesting thing because less being done nowadays, where you have use of interventionalists coming in. Vascular surgeon finds it difficult to have a cardiothoracic or an orthopedic surgeon or a neurosurgeon to join and do a cardiac and thoracic surgeries. Transaxillary scalene muscles are not reachable at all, but you see the scalenus anticus can be divided from below with ease. It is a very interesting thing to do. You need a very good retractor holder. That means a person who is going to assist you must hold the retractor well. And you have a cosmetic line in the axillary skin, and there is no other scar tissue. Sufficient exposure in the first rib. And I told you in the beginning, first rib, as you run your finger, it will be sharp. It is first rib. Second rib is flat. Third is flat. So it is sharp is identified as first rib. Then you push the complete anesthesia, muscle relaxants are helpful, and completely push the vein and artery and brachial plexus up, and then excise the scalenus anticus with a suitable gouge. Arterial scalenectomy, cervical rib excision, ischemic and sympathectomy is used. Subclavian aneurysms and vascular surgery procedures described already. Then comes the supraclavicular access. When there is a vascular surgery as well as a cervical rib, it is ideal to have a supraclavicular access, which gives you the good exposure, but it is not possible for other. Sympathectomy, Atkins was very particular about sympathectomy as axillary approach and the thoracoscopic approach by using the Watts method. And this is a supraclavicular thing, 8 centimeter muscle, sternocleidomastoid muscle. You have an incision from that medial side to the lateral side. And the clavicle is just about 1 centimeter below that. We'll show you a video of how to operate scalenectomy supraclavicular. Mayo Clinic performed 120 procedures in 20-year period. Bruce describes performing over 1,400 procedures in less than 15 years. Probably high volume center is able to manage in Mayo Clinic. Very interesting. Cervical rib and the tendon of scalenus anticus are identified in this picture. Pseudo recurrence, mistaken resection of the second rib instead of first rib. The first rib with the cervical rib left. Resection of cervical rib is an abnormality, first rib remaining any, and resection of the second rib, rudimentary first rib done. Pseudo recurrence. We'll see the supraclavicular cervical rib excision. The video must be available. We'll see. I think you're able to see. You're already here?
Yes, sir. Yes.
Yeah. See, you have the skeletal this thing because of the HRCT associated with the picture. You have the patient positioning and incision. You have the sternomastoid, then you have the sternomastoid. Below that, you have got the external jugular and anterior jugular veins, and you have the brachial plexus on the left side, and you have the clavicle in the base thing. Levator homohyoid muscle is identified, a vein is identified, a sternocleidomastoid is completely, sternomastoid is, yeah, now that you are able to see that sternocleidomastoid is cut to the cladoid portion, clavicle sternal portion, and you will get a good access to the clavicular. Clavicular side is excised, and then you identify the scalenus anticus. And once you identify the scalenus anticus, you will find a phrenic nerve on that, and you have the jugulars medially, and you have the subclavian laterally, and you can palpate the external compressive factor, the cervical rib or the first rib, or extra thoracic fibrous tissues. They are all identified. Now you can see the phrenic nerve there. He is able to identify, and never use xylophane there and that to identify or safeguard the phrenic nerve, because you have other spaces, thoracic, ophthalmic spaces. Immediate post-operative, you will have the sympathetic blockade, which will confuse the anesthetist. You can see that is the phrenic nerve, neatly done. So brachial plexus is guarded with a big retractor, so you won't have any problem except division of bone, which might require special gouge as I shown you earlier. Yes. Thank you. Bundle of brachial plexus. Yeah. Thank you. Questions? Questions from the audience, please. You can put it up. Put it up. What is it? Look at that. If need be, T1 and C8 can be combined. It is called as the inferior cervical ganglion. It can produce, lower half is divided for T1, T2 that gives the upper limb. So upper limb ischemia, we normally divide T1, T2. And it is easy to strip the pleura from the medial aspect of the T1, T2 ganglions and can be ligated, and the Simpson's fascia has to be taken care of so that pneumothorax doesn't happen. Now the bone is now nicely seen now. That is the stump of the cut extra rib. There are some special retractors for that, but single Langenbach is good enough. And this is a good dissection because the single piece is come. Normally you get bits and pieces. And very important to divide all the fascias and tendons, otherwise the extensive fibrosis produces complications. Yes, please, thank you. Anything? Questions, please.
Here from remittances earned by its citizens secretly working abroad.
You're not audible, please.
Sir?
Yeah, now I am audible. Please.
So any questions to Dr. Sivakumar, please, from the audience?
Excess handling of plexus does it cause any temporary paresthesia?
No, it's quite safe as long as you handle it with gentle procedures. But there are certain occasions where you can damage, but never happens. Once you identify major brachial plexus injuries are never this thing, unless he is doing it without thinking it as a fibrous tissue.
There are no questions. Thank you, sir. Thank you so much for such a wonderful lecture. And
Next Saturday.
we will see you again. Thank you. Thank you, sir. Have a nice weekend.